Good evening, ladies and gentlemen, friends and colleagues. Many thanks for taking the time out this evening to come and have our webinar today. My name is Raghbir Khakha, and I'm going to be your host for this evening. And it gives me great pleasure to introduce my friend, mentor, and colleague, Dr. Ronald van Heerwaarden. Ronald doesn't need much of an introduction, but I will go into what we're talking about today. And it's a really good topic, which I know a lot of you have expressed interest about, and we're looking at rotational bone deformities causing anterior knee pain and patellar instability, and we're going to be looking at the latest treatment options. So we are part of Orthopedic Specialists. We work out of Harley Street Specialist Hospital and the London Clinic, and this is Ronald. Many of you will have seen him presenting on many stages, whether that's the European meetings, international meetings, or even at meetings around the UK. He's truly a globally renowned authority in knee osteotomy surgery, and we're very lucky to have him as part of our team. He has been on the forefront of joint preservation and limb deformity correction, and a lot of the techniques we take for granted in our theatres are developed and designed by Ronald, and certainly he has written widely and published widely on joint preservation and deformity correction. His practice is international. He's based largely in Holland, but he also works out of Abu Dhabi, and he works with us in London, and we're truly honoured to have him as part of our team. The Orthopedic Specialist team is made up of a whole host of orthopedic surgeons and pain specialists and maxillofacial surgeons, covering the whole spectrum of orthopedics. And these are just a few of the faces that are part of the team. We're predominantly based out of our hospital here, Harley Street Specialist Hospital, where we do all our consulting and our day case operating. And we're closely affiliated to the London Clinic, where we do our major cases and where we also see patients. So back to Ronald. The things we're going to discuss are rotational bone deformities. We're going to discuss the topic which scares a lot of us, and we just don't know what to do with a lot of these patients with anterior knee pain. And patellar instability is one of those procedures that we know has got multiple operations, and when we have multiple operations, we don't always know the answer. And Ronald's going to give us a clear and succinct way of managing such problems. I'm going to hand over to Ronald in just a second, but just to say that if you're interested in learning about webinars that we might be hosting in the future, or learning about interesting topics, these are our Twitter handles, LinkedIn handles. Please feel free to follow us. If you ever want to get in touch with regards to coming to see us operate, or just simply have a complicated patient you would like Ronald to see, these are our details. Please do not hesitate to get in touch. So without taking too much of your time, I'm now going to stop sharing my screen, and I'm going to hand over to Ronald. Lastly, if there are questions, just some house rules, please put them in the chat or the question and answers, and I promise to go through them with either myself and of course with Ronald. But please feel free to ask questions. We encourage it, and thanks for your kind attention. Ronald, over to you.
Good evening, Rags. Thank you for the very kind introduction. I'm going to share my screen right now to start this presentation. First of all, I hope everything's safe and sound in these very weird times that necessitates webinars as a teaching method. I hope everything turns out for the best, and I can meet many of the participants in the future in well, let's call it live sessions. First one we're going to organize live will be in beginning of March next year as the second edition of the London Osteotomy course. Today we're going to talk about rotational bone deformities causing anterior knee pain and patellar instability, and the latest treatment options for this pathology. As already told, I'm based in 3 hospitals around the world, in Clinic Viasana in Mil, the Netherlands, the International Knee and Joint Center in Abu Dhabi, and London Osteotomy Center, together with Professor Wilson, Raghbir Khakha, and Christian Klei, and other specialists you have seen in the orthopedic specialist group. To go forward from this, let's look at first how the outline of this lecture is. We're looking at rotational bone deformities, anterior knee pain, and patellar instability. And then we look at what is rotational bone growth from intrauterine until further up in growth, and what variations do we see. Then what is the relation between rotational bone deformities and patellar tracking? Why does a bone deformity in the transverse plane, a rotational bone deformity, cause patellofemoral pain and patellofemoral instability? And then when to suspect that such a deformity is present and causing the complaints the patient presents with. The patient presents with patellofemoral pain and patellofemoral instability. When to suspect that something other than the normal things is present, and how to find a rotational bone deformity. And then the latest on rotational osteotomies. And that is more like, what options do we have in this field, just to show you and also to talk about the results, particularly related to patellofemoral tracking, pain, and instability. Okay, let's go ahead. Rotational growth. These are intrauterine views 7 weeks from gestation, and then on from that point. On the left side, upper part, you see here, you see the arm from a little butt out of this child in growth, in intrauterine. There is a formation of an arm, an upper limb. The arm needs to rotate dorsally. So this is a view at the start, and then while growing longer in length and creating fingers at the end, a rotation has to take place until we have a limb that is rotated in the right direction. So the arm needs to rotate dorsally. The opposite is true for the leg, and we're concentrating this lecture around the knee and the leg, and this is a knee in progress, gestation 7 weeks. We're down the road from gestation, and there we see already the butt here from the foot, and then ventral rotation needs to take place to give the right orientation to the leg. So here you can easily see that that's the knee joint, these are the feet, and a rotation ventrally has to take place for the legs to come in the right rotational position. And it's, if you really look at it more deeply, which we're not going to do during this lecture, it's really a miracle that everything goes the right direction and goes right. Those of you who are children orthopedic surgeons, especially in academic hospitals, see the variations and the pathology when something goes wrong during intrauterine growth and the deformities that come from that, part of that, rotational deformities. Now, when the child is born and in the first year, you see that the child wants to start walking, and we stimulate the children to start walking, but they all have in-toeing, as we call it, inwardly pointed feet at that stage. And if you see a child balance on his leg when he wants to stand up, the foot is pointed inwardly. That's normal. And through growth from that point on, in the first year and later on, specifically when walking, the femur as well as the tibia rotate externally. Now, what is a normal growth development in rotational growth look like? The femur, normal from intrauterine at birth is 40 degrees anteverted, the femoral head, relative to the femoral condyles distally. At like 10 years of age and into adulthood, this is the development. 20 degrees and 10 to 20 degrees is normal as a femoral anteversion. Tibia version at birth internally rotated. And that's also a little bit already growing lateral towards neutral in the first year to 2 years, but with stance and walking, it develops more in a lateral version, which we call a tibia version growth. It grows externally up to about 20 to 25 degrees to adulthood. There is a variation though in parts of the world. So Asian population, you will find less of an external growth of the feet, and it's quite normal to have almost neutral or only 5 or 10 degrees of external version as compared to a Caucasian population, which is quite normal to have 20 to 25 degrees external version of the tibia. You hear me repeatedly say version. Torsion is pathology. So if you have a tibia which has a external rotation of like 45 degrees, we call it a tibia torsion deformity. And the femoral anteversion, normal values 10 to 20 degrees, and we call it above 20 degrees anti-torsion. So that's the terminology that goes with that. Now, when a child grows beyond like 1 to 2 years, you may be faced with a growth variation. Now, you meet here my daughter. This is at 2.5 years old, and she could perfectly sit like this, and I investigate her at that point, and she has increased rotation in one direction, but she cannot rotate. This is the right leg rotation in prone position beyond 0 degrees. So she's very far, the internal rotation, she cannot externally rotate the hip. So I'm looking at the foot position in a bended knee, prone, and the foot position is externally rotated. So the version of the foot is quite normal. However, this is not normal. Well, I'm a doctor, I'm interested in deformities, but this is my child. So am I worried? Well, a little bit, but I'm happy to know that this may compensate to normal during growth. And we see that in the majority of children who present with this on clinical examination, anti-torsion of the femur. This is a typical investigation for anti-torsion. Now, so more than 90 degrees, coxa antetorta have a spontaneous correction before the age of 9. Now, this is her at the age of 12. When I ask her to sit exactly the same as the previous pictures when she was 2.5 years old, it's hard for her to even do that. And this may not look very elegant, but she could never do that at age 2.5. Now she can do that. And if I investigate her while prone, this is the excursion now. She cannot do it all to the floor anymore. And now she has reached a symmetric rotation, internal as well as external rotation. And this is beyond the 0, the neutral. So through spontaneous growth, through the years, she has corrected the anti-torsion deformity that I found when she was young. And she has a little bit of high anti-version or a lateral version in the tibia on both feet, but that's within the normal limits. So, happy dad, I'm happy. I do not have to do any correction in my own child. Now let's have a look at this young lady. She is beyond rotational growth now, and she presents with this. Obviously, we see that her knees are extremely inward rotated. We call that kneeing in. She has an unstable walking pattern, and when asked to put her kneecaps forward, look at where her foot positions. These feet are pointing far beyond normal outward. So to go back, feet forward, the knees are extremely pointing inwards. Bending her knees touch immediately. And when we put her kneecaps forward, her feet are pointing outward. There is a name for this combination. It's called miserable malalignment deformity. And while we see kneeing in combined with toeing out, we know from gait analysis alone that there is a high suspicion of a femoral internal rotation deformity combined with a tibial external rotation deformity. Now, what's the relation between rotational bone deformities and patellar tracking, patellar pain and instability? First, then you have to realize that a antiverted hip causes a kneeing in and a toeing in. And for me, I started to realize what was happening when I saw this graphic. So here you see a hip which has a much more antiverted angle towards horizontal than is normal. So, of course, you can position the patella and the foot forward. However, in this transverse section, then you have to put the hip into an extreme anti-torsion position. Now, the hip doesn't accept that. If you want to walk forward and if you want to stand, the hip wants to rotate and position itself in a normal antiverted position. So this is what happens. When the hip position between 10 to 20 degrees, which is the normal position, the knee has to rotate inwardly and the foot has to rotate inwardly. And because of that, you have a kneeing in and a toeing in a hip which is antiverted, has anti-torsion, too much from normal. And when walking and standing, the hip joint dictates that it goes back to a normal anti-version position in the hip joint. And that causes kneeing in and toeing in. Now, if you look at this knee position and you compare it with this knee position, you can already see what happens to the patella. The patella wants to have a face forward position, and here it's facing inward. And then it wants to track. What then happens is this. With an inward twisting of the femur, the patella wants to go outward because the trochlea goes inward. The patella doesn't go with that. It wants to go outward because the quadriceps pull is a straight pull upwards. So an inward twisting of the femur causes a force factor laterally acting upon the patella and also stress on the medial patellofemoral ligament. If then you have an increased external tibial torsion to go with that, as in this young lady who had a combined femoral as well as a tibial deformity, you have a walking pattern that you can explain in this drawing. A valgus walking pattern with rotation, which increases the tuberosity position to go lateral, and double force factors acting on the patella to move the patella outwards. Internal twisting of the femur, external rotation of the tibia, both cause a rotation outwards of the a force vector outwards in patellar tracking. Here you see what that causes regarding compression of the cartilage. This is a normal balanced compression, medial as well as lateral, and we all know a little bit more lateral compression is normal. This is the trochlea area, and the patella is centered centrally. Tension on the medial structures is normal, as well as on the lateral structures. Now, this is after an inward twisting of the knee, as in a anti-torsion deformity of the femur. So inward twisting, like you see here. Immediately, you get tension increase of the medial capsule. The patella moves outward, and this is why you have more compression on this part of the joint. The lateral patella hyperpression pain can be explained in this drawing, and also the instability. We know the majority of instabilities of the patella is a lateral patellar subluxation and luxation. If you twist the patella inward, this is where the patella goes. So instability of the patella and hyperpression of patellar cartilage is explained in this drawing, where you see an inward twisting of the knee relative to the patella. Anterior knee pain and instability of the patella by that are explained, and the relation to a rotational bone deformity is explained. If you want to read more about this, the Frank Noy's Knee Disorders book, published in 2010, is a good book, and actually these drawings are from that book. Now, you already heard some of the terminology involved here: kneeing in, kneeing out, toeing in, toeing out. We can all see that in a gait observation of a patient. Torsion is an abnormal rotation of a bone. Version is a normal rotation. Then we have, with anterior knee pain and knee instability, we have patella baja, patella alta, hyperpression, lateral tracking, hyperlaxity, trochlea dysplasia. We are not going to talk about that in this presentation. We'll concentrate more on the rotational deformities of the bone. But I hope the relation between the two of them is clear. Now, the problem is the pathology often goes unnoticed. That is why these patients are hard to find or present late. These vague complaints involve at the hip joint, groin pain, instability complaints of the hip, trochanteric bursitis, some mobility loss, impingement kind of complaint, and if there is a retroverted hip, there is a very early cause of hip osteoarthritis, which we often see in families. That's genetic dysplasia. At the knee joint, most of the complaints happen. The patella doesn't like a tracking in a rotated leg. So patellofemoral pain, instability, osteoarthritis, in the end related to chronic rotational deformity, is very well known. Tibiofemoral osteoarthritis is not so well known, but is related to tibial internal torsion. Osteochondral lesion, osteochondritis dissecans, has a relation to torsional deformities. If you rotate the torsion, sometimes there's a spontaneous resolve of a osteochondral defect in a growing child. At the ankle, gait abnormalities, fatigue during walking, such a vague complaint, but we see that all resolving after we correct these deformities. And also, specifically in post-traumatic cases with rotational deformities, osteoarthritis may have its course during the years in the ankle joint. But in general, these complaints are not so easy to connect to the rotational deformities that are not easily to visualize when you're not looking for it. So we did some work on that, we checked on this, and from the child, we now go more to the adults. Now, look carefully at this walking video. This is a patient I saw after she had 20 ORs for patellofemoral complaints, pain as well as instability since 14 years age. She remembers that 2 ORs, quite in the beginning, were in the high tibial area. And these happened to be rotational osteotomies. Look at her walking. So this is a lady already in adulthood. I think she's at her end 40s. Look at the foot position. This is toeing in gait. Toeing in gait, patella facing forward, toeing in of the feet. And remember, she had ORs at the high tibia area when she, as a 3rd and a 4th OR. After that, she had ORs for patellar instability, arthroscopic views, some cartilage work around the patella, and it didn't work at all. And now she comes with complaints still persisting since 14 years old and many surgeries. Now, I was the lucky one to do the 21st and the 22nd OR, and you can already guess what I was doing. And look at the result. Now you see her walking after a derotational osteotomy, and then what the aim was to position the feet normally in slight external rotation position relative to the kneecaps. The 23rd and last OR, because she had a big improvement on her patellofemoral complaints, were the hardware removals for both legs at the same surgery. Just to explain to you, ask around the history, even if there are many surgeries before, and sometimes you will find the situation where already there has been, of good cause of course, and as a good try, a rotational osteotomy, which in this patient turned out the wrong way. This is from Linsta Haley's book. How do you find rotational deformities? Now, you have seen some examples already. We look at gait. We look at the foot progression angle. How are the feet positioned? And this is in a child, but we do the same in adults. We do the same in older people. We look at how the foot are positioned. And this is the first part of your rotational profile examination. Then we put the patient prone and we rotate the hips, as you already have seen in some of the previous slides. Internal and external rotation of the hips, and normally you have a symmetrical excursion there. However, it's asymmetrical. You start wondering, is something wrong here? Especially if you cannot rotate beyond the neutral as you look at it as a clock. Then you look at the foot when the knees are, when the knees are bent, and you look at the foot position. And the foot should be externally rotated to some 20 degrees when the knees are bent and the patient is prone. You have to also look at the foot shape itself, because sometimes there is an adduction in the forefoot, which also causes a toeing in. But normally the rotational alignment investigation looks like this. So you know how to analyze this on clinical examination. But sometimes, even I've seen many patients present with very weird tricks they can show. Look at this extreme possibility to rotate the legs and to position the legs. And this young lady has a isolated femoral deformity on both sides. Here you see again the rotational profile examination, and this is the rotational profile in this patient. Sorry about this. So here you see it. She has extreme rotational, internal rotation. She cannot even reach the neutral to go over the neutral to the other side with external rotation of the hip. And she has normal position of the feet with bended knees. Now, you've seen what we see in our patient populations and the variations we see. Now, how do we treat them? And these are just examples of the treatments we use and the different levels we perform the rotational deformity corrections. In the femur, you can choose to correct at the proximal level. This is a subtrochanteric or intertrochanteric osteotomy, and normally we use blade fixation conventionally from AO, and we use these small triangles to help us guide the rotation we have to aim for. We put on each side of the projected osteotomy cut, we position K wires, and then we make the cut, and we rotate the K wire, we rotate the leg until the K wires are parallel. So this is an example for offset placement of the K wires and rotating until they are parallel. And then fixation with a blade plate, and that works fine. And this is during the surgery itself. Nowadays, we like to perform our osteotomies in the femur more towards the knee joint. It's easier for the patient to rehabilitate from that, and it's easier for the surgeon to perform this surgery. And this is an example how we do that step by step. This is the lateral side of the distal femur. This is where we will make the cut. We position the K wires on both sides. Before we cut the bone, they are parallel, and we have a rotation tracker, and this is after the rotation. And then we position a plate for fixation, and here you see the cut, the plate fixation from lateral, and we use angle stable plates for these surgeries, and this is the end result. So this is just an example of a distal femoral rotation osteotomy to correct increased anti-torsion or retrotorsion. So an anti-torsion deformity or a retrotorsion deformity. I already showed you a patient which had a torsional malalignment or miserable malalignment syndrome. And we can also do in one surgery a combination of a distal femoral rotation osteotomy and a proximal tibia rotation osteotomy. In this patient, we also had to correct some valgus, so we chose to, after the rotation, to position the plate on the medial side, and the lateral positioned plate we always use for the lateral, for the proximal tibia rotation osteotomy. So this is a combination of rotational deformity corrections in a patient which presented, here is the leg, with a femoral as well as a tibial deformity. Now let's have a look at this young lady. The history is dramatic. She already had complaints of her knee and her kneecap with pain and instability at age 12. She had seen, before I saw her, she had seen many colleagues, the last one, an orthopedic surgeon, already 5 years ago. So now she presents at age 17, 18, I do not know correctly anymore, with this walking pattern. And the house doctor says, can you please have a look, because she has valgus. Can't you correct the valgus in this young lady's leg? Now look at her walking. You see a very unstable walking pattern, and actually at that time she's walking normally with crutches. because of the pain and the instability in her walking pattern. If you then make an X-ray to show her whole leg, the leg is perfectly straight. So this patient doesn't have valgus because of a deformity in valgus in the femur or the tibia. These bones are perfectly straight. And this full leg weight-bearing X-ray, as it is called, is made with the patella forward. That's the standard projection. However, the feet are far from forward in this projection. This young lady, her clinical examination looked like this. So she has rotations like this, which is large. However, it's also symmetrical over the midline in both legs. But now look at the foot position. The foot position is far from normal, especially on her left leg. So she's prone here. This is the left leg. So she has an external torsion of her foot. And that is why and let's look again at her walking. When she wants to walk forward with her foot, she needs to extremely internally rotate her knee. So kneeing in extremely and causing a seemingly valgus walking pattern, which is caused by a rotational deformity. This is a proximal tibia rotation osteotomy. This is 6 weeks, this is 3 months, full bone healing. This is the young lady walking at 3 months. Now, you understand that this, for her it's like near a miracle, because she came with crutches before the surgery, and she had that walking pattern. And she had many specialists already seen, and in the end, this is a surgery of like 40 minutes, and then the bone healing. So it shows how powerful a rotational deformity correction is in patients if you recognize it. And that's the problem. If you do not recognize it, these patients are wandering around having severe complaints and are not being treated well. In the proximal tibia, you can choose different levels, and I won't go into it too deep, but if you look at this, you have like 5 different options in the proximal tibia for a rotational osteotomy. If you make your cut above the tuberosity and you rotate the foot, you also rotate the tuberosity with it. If you make a cut underneath the tuberosity, you rotate the foot, then nothing happens to the tuberosity position. We'd like to prefer our cut at this level, at the metaphyseal level with good healing bone. And then we can choose either to rotate the tuberosity with the rotation of the foot or not rotate the tuberosity. The tuberosity here is attached to the proximal part. And when we rotate the foot, nothing happens to the tuberosity position. And then we have cases where you have an extreme abnormal position of the tuberosity. We make a full tuberosity cut, we rotate the foot, and we fix the tuberosity at the right position. And that we know because we do these TTTG measurements, which is the tibial tuberosity compared to the trochlear groove. So this is the normal position, and we use that as a reference in these patients. We can make like of predictions. If we make a cut and we rotate the foot as well as the tuberosity, how far will the tuberosity medialize? And then we can combine a medialization of the tuberosity with a internal rotation of the foot. And this is just a rule of thumb. So in the patella tracking field, it's very important to know where the tuberosity is, as this is by itself, the tuberosity position also may cause patellar instability. patellar hyperpression and patellar pain because of a lateral position of the tuberosity, lateral to normal. And if that's present, together with an external torsion, you may choose for a combined correction, a medialization as well as an internal rotation of the foot to normal position. Now, this is such a surgery. This is step by step. It's what we call an anterolateral approach. We are looking at the tuberosity area here. We can already look where the plate will come in the end, and position from the plate are position of the transverse cut of the tibia. In this case, we wanted to do a variation where we do a proximal tuberosity cut. It was already made here, and after that we made the transverse cut. So that means that while rotating the foot internally in this patient, we intentionally also medialize, with the rotation, we medialize the tuberosity. This is parallel K-wire position, externally, external torsion deformity of the foot, the transverse cut, K-wires on both sides, and then we internally rotate the foot to normal. This is a tracking device you see here, where we exactly measure from the CT scan values how much we want to correct. And only if the K-wires are corrected in that position, we mark the bone and we fix the bone. And this is the bone fixation afterwards. And here you see it graphically. Now, up to 20 degrees of rotation is possible in the proximal tibia without making a cut of the fibula. And the peroneal nerve will not be stretched beyond its length there if you stay lower than 20 degrees. If we need to go for a rotational osteotomy higher than 20 degrees, then we choose the level below the distal tibia level for rotation. Then we have to also cut the fibula. So here you see an example. This is obviously a post-traumatic case. Nail fixation, larger than 20 degrees deformity. This is shown here. And we correct at the distal tibia level, and we combine that with a fibula osteotomy, which you see here, to a normal position from a very abnormal post-traumatic situation. So larger than 20 degrees corrections we'd like to do at the distal tibia. And it's the same bone. And again, there, the nerve is not at risk at that level. So what are the results of these kind of surgery? Well, there's dramatic improvement of anterior knee pain complaints, a decrease of that, of these complaints, when you have an excess femoral antiversion or anti-torsion treated by a hip rotational osteotomy. This is 48 cases, and the series is much larger than this, but this was presented at one of these courses. 95% of the patients would have the surgery again. Kuyala scores, Lissom and Techner scores are all scores on function, and Kuyala is more specific on patellofemoral pain and patellofemoral tracking, and dramatic increases of these scores, which is a dramatic decrease of patellofemoral and anterior knee pain. Femoral anti-torsion and retrotorsion, intertrochanteric osteotomies, and that's specifically for retrotorsion, improve the hip motion and loss of pain, especially in retrotorsion hips where there is early osteoarthritis. Miserable malalignment, as reported by Delgado already in the 1990s, decrease of knee pain, gait pattern improvement by combined distal femoral and high tibial osteotomies. Patellofemoral problems and tibial external torsion, almost 90 degrees, 90% good to excellent results, 83% pain relief, and only in 5% of the population a residual instability complaint of the patella. The same results in our own clinic in 23 internal rotation and high tibial osteotomies for external torsion deformities. mean 9 years follow-up, and very high improvement of Kuyala scores. 17 of 18 patients, so there were patients who had it both-sided, would have the surgery again as a patient-reported outcome measure. And again, from another group, this is from Canada, good results with these rotational osteotomies, large improvement of Kuyala score. So if you want to talk to your patients and talk about the results of, for example, these rotational tibial osteotomies, 90% have very good to excellent result in the resolve of patellar instability, even 95%, as well as patellofemoral pain. No surgery without the chance of complications. This is on the neurovascular structures. Twisting of a nerve, there is a limit to that. Very large corrections, we need to release nerves to prevent stretching, to prevent neuropathy because of our surgeries. So that's all described in the literature. This is out of an own publication, and we know how to deal with that. But it is a complication of such a surgery. So we're talking to patients about these complications. So there is literature. There's not much. Some of it is own publications. There is some increase in the recent years in the literature, and also about the excellent results of these rotational osteotomies, because more and more of our colleagues are doing these rotational osteotomies because of the dramatic improvement we see in these patients, in gait, as well as the decrease of complaints at the hip, specifically the knee, and at the ankle. Take home messages from this lecture. I hope in your next bunch of patients you see, specifically with patellofemoral pathology, check for the rotational deformities. It's easy to do. It takes maybe 20 seconds of your clinical examination. Look at the walking pattern, put the patients prone on the bench, rotate the hips, look at asymmetric rotations in the hips to check for femoral rotational deformities, look at the foot positions with the knee bent for tibial rotational deformities. This simple rotational profile examination will put you on the right track. And I guarantee you, in your next 20 to 30 persistent patellofemoral complaints patients who have had all kind of conservative treatments or even have had previous surgical treatments for their patellofemoral complaints, you will find patients with a rotational deformity. And remember this, the bone always wins. So whatever soft tissue procedure has been performed, whether it's an Npfl reconstruction, which is very popular these days, whether it's a lateral release, less popular these days, whether it's any kind of arthroscopic treatment or any kind of other patellar stabilization procedure, if there is a rotational deformity in the femur or the tibia, or in both, the bone will win. The patellar tracking will be abnormal, and you will have a stretch of your soft tissue procedures. And you will have still a higher compression on the patellar cartilage, which you may have treated for the good, and the complaints will come back in these patients. Treatment results of anterior knee pain and patellar instability patients with rotational deformities are good. And you will find more and more of these treatment results in the literature. And if this is not your cup of tea, if you have these patients and you think, well, I know it's there, but I'm not going to treat them, this is not what I'm going to do, please refer these patients. We can easily treat these patients if you have already examined them and found the deformities, or if you are in doubt, refer them to the Harley Street Specialist Hospital in London and give them a chance, these patients, because these dramatic histories we see over and over of these patients with long-lasting complaints for even many years, it's very disturbed gait abnormalities. Many of them are being treated in series of surgeries or one surgery to correct all with very dramatic good results. I thank you for your attention, and I give the word back to Mr. Raghbir Khakha for some questions on the topic. Rags.
Cheers, Ronald. Ronald, what amazes me, I've heard you speak so much, and I always see new slides and lots of new information, and it's a real learning point for all of us. And just to emphasize the take-home messages, these patients, we have all seen them in clinic. At some stage in our careers, we will see them, they come and present to us, and they're often mislabeled as being difficult patients, and not we're not able to deal with them. But there is a solution, providing we find the right examination, follow the right examination, and find the pathology. They're really treatable. So Ronald, we've got some questions here from a combination of our orthopedic colleagues and physiotherapy colleagues. I'm going to start off with the first one from one of our physiotherapy colleagues who's asked, they've had a lot of patients who do ballet, and in fact, I think this particular person does ballet themselves. And what they've found is that they present with these typical findings of interring while they're sort of practicing. And as time goes on, when they do their sort of ballet and their conditioning, they resolve. What are your thoughts about that, Ronald? Is this something that you see, depending on the kind of sports they might do? Is this just something that will get better itself?
No, especially ballet, people who are in ballet, they have extreme excursions, because the whole learning of ballet and becoming very good at it is about all kind of stretching exercises to an extreme for the capsules in the hip area, at the hip joint. And that is what you see. You see these athletes, because they are athletes, present with gait and gait abnormalities, which you think may be caused by a bone deformity. I have seen ballet dancers who had a bone deformity. However, they could compensate for that because of their very extremely stretched capsules in the hip. That's abnormal, of course. That's an induced pathology by sports. However, there are only few rotational deformities that are very beneficial in sports. And ballet as a sport, and these athletes seem to have a capability to correct it, but you have to realize that during their training, they have stretched their capsule to an extreme. Some of our patients, though, who present with abnormal gait, do not have an abnormality in the bone. So I'm very reluctant always to immediately classify them as, oh, you have a bone deformity. The CT scan in combination with clinical examination has to prove that. And there are patients who have, and specifically the pediatric colleagues know that there are also spastic children or imbalanced children with muscle imbalances around the hip joint, which are so abnormal that in the soft tissues, in the muscles and the muscle tension, is the cause of a rotational deformity abnormality during gait. And then it's not in the bones, and you can only find out by making a CT scan. So it's rare, but it is there.
I hope that's very clearly answered. Thanks, Ronald. And we're lucky to have one of our senior surgeons around London, Mr. Matthew Barry, who's asked a couple of questions. I think one was answered really well earlier about the neurovascular compromise. So the question was, with a proximal tibial internal rotation osteotomy, are you concerned about nerve stretching? And I know you answered that with the sort of increased degree. Ronald, is this something you've seen, and what's your experience with this?
Well, as always, you learn by doing and being very careful in the beginning and being more bold later on. But of course, I have my complications. I've had them. And particularly I remember one of these girls who had a post-traumatic situation where, on hindsight, I should have made MRI scans to see where this nerve was captured around the knee in scar tissue. So she had a drop foot immediately after the surgery because the stretching was too much of this nerve that was captured in scar tissue. If you are worried about the amount of rotation and whether or not the nerve can deal with that, I'd rather go for a release of that nerve, which is beautifully illustrated and described in the books of Dror Paley, who is a deformity specialist, where he shows with a release of the fascia in the proximal tibia area, in the anterolateral compartment, you can free up that nerve. And whether you internally or externally rotate the proximal tibia, the nerve is free then. I'd rather not do an excision of the fibular head because of all the attachment of other structures. But that's the point in the leg where most of these traction lesions happen. And if you put your retractors, of course, around the bone, you prevent for any cutting damage to the nerves or the vessels. But the traction lesions and the neuropathies resulting from that are localized around the fibular head and the area where that nerve is captured in fascias.
Got it. Thanks, Ronald. Just a couple of more questions. Another really good question, something that we've discussed at length in the past, once again posed by Mr. Barry. So if there's an Npfl rupture and there's a rotational malalignment, do you correct rotation first and see what happens to patellar instability? Or do you correct the rotation and the Npfl at the same time? Which is a brilliant question. I know we've talked about this at length, Ronald, so over to you.
Yes, well, there was a time before these very now popular Npfl reconstructions with the newer techniques. And at that time, we didn't do these Npfl reconstructions. And out of a series of these rotational corrections in the femur, where you essentially rotate the trochlea underneath the patella to recreate a normal patellar tracking, there was no instability of these patellas anymore, provided that the patella shape is normal and the trochlea shape is normal. However, if you have, while then testing intraoperatively after your rotation, you have still a very lax lateral luxation situation of the patella. Nowadays, we tend to combine the techniques. So if you have scar tissue and not so very lax patella, and after your rotation of the distal femur, positioning the trochlea under the patella, you do not need an Npfl reconstruction. If, however, then still that Npfl is so lax and the medial capsule is so lax that you can luxate the patella laterally, then we add a Npfl reconstruction. I hope that answers the question.
Yeah, I mean, we've done a few together now, Ronald, haven't we? And
yep.
We have noticed that once you've corrected the alignment, as you said, the bone always wins. And that's a really key message to everyone listening, that actually, if you correct the rotational alignments, you know that not everybody needs an Npfl reconstruction. And then I think we'll sign off for the last question, which has been asked by two different people, a friend and colleague, Sunil Jain. What is the minimum threshold to consider correction, both in the femur and the tibia?
Well, in the femur, the threshold for Caucasian population for me is, first of all, on clinical examination of gait and kneeing in, and a CT scan analysis, anti-torsion 20 to 25 degrees minimum. Then I would consider a correction. In the tibia, Caucasian population, 20 to 25 is normal. We have a standard deviation up to 35 degrees and above 35 degrees with clinically a kneeing in and or towing out gait and the complaints that come with that, then I would consider a rotational correction in the tibia. I know you will find other values too in the literature. So there is a spread in what we call the reference values. I have studied this a lot. I've based this on values from previous articles and previous authors. And I can only tell you that in my experience, these reference values work. And you can try to go with other reference values, but for me, this is a well-established reference value for femur as well as tibia.
Brilliant, Ronald. That takes us bang on time for 7:30. So if you wouldn't mind just stop sharing your screen for a second, Ronald, just so I can bring up a last slide to show everybody. While you're doing that, it's good to have Professor Adrian Wilson join us now as well. Adrian, as a lot of you will know, has led on the front of osteotomy surgery in the UK and internationally. And he set up the London Osteotomy Centre, which we are all on the team for. So he's on the panelists view now. So I don't know if you can hear us, Adrian, but I'm just going to share my screen, and just to sign off. Firstly, just to show you a slide that if you do want to get in contact, or if you do want to refer a patient, or if you would like some more information, these are our details. Please do not hesitate to get in touch. Or visit our websites. We're constantly putting up case studies. The common question has been, can we please see the video online? We've got our own YouTube channel. So if you go to YouTube and you type in orthopedic specialists, you'll be able to find our channel there. And the webinar will be posted onto the YouTube channel. So you can go through the talk again in your own time. The London Osteotomy Masterclass is going to take place next year. And we'll be posting that on all our forums through Twitter and LinkedIn, and through your emails. Now, this is going to be really a similar theme to what we've just had this evening, going through the advanced elements of osteotomy surgery, starting with looking at the different types of osteotomies. And we're also going to increase the theme and looking at comparisons with when do you do osteotomy, when do you do arthroplasty, when do you differentiate between the two? All the questions that we all typically have the question for, but never really know the answer. We hope to be able to answer that for you with a stellar lineup. It's going to be held at Lord's. So I really hope you guys can make that. Brilliant. So without further ado, I'm going to close the session there. Thank you so much, Ronald. Really appreciate you taking your time to do this for us. And thank you to all our participants and attendees. We'll send you out a questionnaire following this talk, and we'll be able to issue you with a certificate for attendance, and CPD points have been awarded for the session. Thanks once again. Bye-bye.
Thank you.